Okay, this next panel is about collaboration and how to maximize it, enhance it. And I think we'll start with Dr. Zaldiravado and Altamirano, who I think have a few slides to tell us a little bit about their collaboration, their successful collaborations that have resulted in R01 funding, and some great insights. Do we have slides for them? No?
Yeah, that's still good, right?
Okay. All right, so if those slides are up first, maybe we'll go with you, Trish. Sorry, guys, if you don't mind, let's have Trish tell us a little bit about what she's doing and how we might collaborate with her. Her counterpart, basic science counterpart, is Dr. Lee Lai.
Yeah, so we're pretty... So our collaboration is really quite new, but this whole field is brand new. So I think that Dr. Lumsden mentioned in the beginning, a brand new way that we're approaching critical limb ischemia is to do deep venous arterialization. So for patients who have no option but an amputation because they can't get blood flow down to the foot, one way we're doing this now is connecting the artery to the vein so that the vein actually perfuses the foot. And what's thought is that there is this fundamental change that happens over time where the veins turn into arteries, and now we have new types of cells that are able to go on to heal the wound. If you just go to the next slide, then so my lab deals with MRI imaging and how we can characterize lesions, but also characterize the anatomy as well to have an idea of who's going to be a good candidate for this type of intervention. But we also do the histology afterwards as well to get a sense of whether one set of patients will go on to heal, another set may not. And so with Dr. Lee and Dr. Yu, we're trying to combine the information that we have so that we can start to see whether there's differences that we can identify a priori so that we know who is going to be a good candidate, but also what is the mechanism, what is happening, why can some of these patients heal in the first place?
So let's turn to Dr. Lee Lai to hear about how you're going to look at the mechanisms of this. I mean, clearly something must be going on with the microcirculation, right, with this procedure.
So I think being in the hospital and can be able to talk to the physicians all the time give me a lot of privilege to understand what is the clinical problems and then combine with the knowledge that we gain in our web bench, then we can kind of see if our hypothesis also can explain the clinical troubles. So in our lab, as Dr. previously introduced, so we found this new mechanism for vascular recovery, which is we can turn, with the help of the innate immune activation, we can turn the fibroblast cells into endothelial cells. So in a lot of cardiovascular diseases, we can find that there is activation and over-proliferation of fibroblast cells. So in our concept, it's very ideal that we can turn this excessive and over-proliferated cells into some cells that is really in need. For example, endothelial cells, that will be ideal therapy for us. And with collaboration with Trisha Roy and also Rahimi, and we can kind of study if this phenomena also contribute to this deep venous arterization pathology. Since I think, based on what Dr. Roy just explained, that we kind of turn this venous into arterization, right? So this process got to involve some cell phase transition process, which is really fits into our hypothesis. So I think in the near future, we're planning to collect some tissues, very well classified tissues from the clinic, and then we're going to work with Dr. Wang and using his cutting edge algorithm, and we'll have some candidates that could potentially contribute to this pathology and also our new mechanism for neovascularization. And also in our lab we have a system to kind of in vivo screen all the candidates using our animal model. So it's a very connected and synergetic groups that we have.
Thank you, Dr. Lai. So that's a new collaboration that's just starting. Let's have the next slide. Is there another slide? Maybe not. Okay, so let's talk about next a collaboration that's more mature, and that's the one Drs. Valderrabado and Altamirano have been working on, a very successful collaboration. So guys, tell us how that started and where you are now with that collaboration.
So it started out of my frustration. When I came to Methodist 2006, I had the illusion that I could still be a physician scientist and lead a PC clinical practice that is procedural. And that out of, reality checks, it became obvious to me that I could not lead both. I could not lead a basic research laboratory, and I could not lead a clinical practice that was procedural with all that includes. And my lab went into stagnation. We produced something, but we never got NIH funding. But my clinical practice did grow significantly, and some clinical and translational research evolved out of that. But I begged the administration to help me hire someone that could really synergize with me. But having been in the lab and in the basic research lab for a number of years, I understood why many clinician to physician to biologist collaborations never worked. And I knew the biases that contaminate that collaboration many times, which is, the clinician thinks that they own everything the scientist does. And that is a no-no. That's a non-starter for any collaboration. But anyway, after you came, you supported this idea. Dr. Zobi supported this idea. And then we did a search and we found Francisco, who was coming from his lab, had done several postdocs, had a scientist developmental grant from the NIHA, a hot postdoc from a very prominent lab, and who had the energy and the drive. And I was very clear as to what I expected him. I expected him to be leading the basic lab. I had no ambitions and no claims of leading that lab anymore. I wanted him to be independent. But in exchange for that, I wanted him to have coffee with me and listen to my concerns and my needs and accommodate my needs. I did not expect him to work for me. I wanted him to have his projects and then work with me in the area that we could have synergistic collaborations. And after a year of coffee in the morning at 7 a.m., we would meet every Monday and discuss. And sometimes we would talk about the news. And sometimes we would talk about the actual next steps. And then over a few months, we said, okay, next week we will have the first page of our grant, the specific aims page. We should have a draft by next week. So I came up with one. He came up with one page, and then we iterated over many weeks to months. And then, of course, you need also not just coffee, but also the pressure and the stress to say, okay, this is the deadline. We have to come up with an application that's viable by whatever time. And then we came up with one, and to our surprise, we put together a grant, and Francisco did a lot of the stuff that in my writing was really weak at some point, the biology, the sophistication. He coordinated the collaboration with 1U. So we added a lot of biological sophistication that I was not capable of putting into a clinical-oriented grant. But the grant has, basic science, engineered tissue that he does, has animal experiments that I do with his help, and has patients that I put in. So we go from the cell to the human. And our goal was that the first submission would not be triaged, and it got funded. So it's nice. Now, you can give your perspective, Francisco.
So I think that one of the greatest things, is not the grant, it's the coffee. Like, it was at 7 a.m., so for me, basic scientist was difficult, and of course, Dr. B is busy at kind of you need to be there, and he will reschedule, and I understand that. So it's flexibility, they are busy, and we can find time, and it was great to talk and develop trust. And I think that I feel that I can talk with Dr. B if I have a problem. And to tell you the story, we thought that we will send this grant as an R01 for experimental humans. And we prepared everything. And the day that we're submitting to the grant office, we realized that NHLBI does not have that grant mechanism. So Dr. B was in Spain. And I text him, and he kind of started writing, some documents. And then I tried to fix it. And at that point, Ravi was here, and the grant office gave us all the SF-424 forms that are the NIH forms that we need to complete. And I was completing them, and error, because you need this human study. And I was texting Dr. B. And the first thing was the trust of that. Hey, we need these documents. Can you send it to me? And he did, we submitted the application. And that is the first, I think that I trust that we won't have a problem because we know each other and we can talk. And everybody can kind of be successful. He can get his corresponding outdoor paper. I can get it. We can develop new grants. And the other is that as a basic scientist, we think that we know everything, but it's not the case. So it's amazing going to a large animal procedure and see a real AV node ablation and kind of see the real things that will happen in a patient. But then I will collect those tissues and I will collaborate with Dr. Wang when you kind of to get all the data from the cells and the sequence, and kind of I can get the best part of both worlds. So I think that is amazing. And both of us can thrive in the collaboration, not one or the other, both. And I think that's great.
Beautiful, beautiful. Tricia has a comment.
So, how did you guys get the funding to get the preliminary data in order to write a grant together?
So I had some from the endowed chair, and I had some money. When I tell you that we submit, and the first time we submit, we get a grant funding, it's a fallacy, because I've been working on these ideas for 10 years. In 2015, I submitted a grant that was triaged, and most of the foundation of this one that got funded were pieces of that. And so nothing just develops overnight. But as far as the money, Francisco, you had some startup funds too, and I had some money. It didn't take much. I mean, it took a couple. We had maybe 2 animal experiments, and I had a lot of human data that and the key also, if you're a BC clinician and you get the pressure for RVUs, I don't know if Dr. Zobi stayed here, yes? So you have to have a research protocol that is aligned with the clinical practice. It cannot be that you go from, salvaging a limb to looking at intracellular calcium. It's just too hard. It's just too hard in the same day. But if your research is aligned with your clinical practice, and the one we have, I'm doing AFib ablations, and we have to stop ventilation during the AFib ablation because a matter of safety, the patient moves too much. So we have apnea. So the study is about sleep apnea and AFib. So it's aligned with my clinical practice. Everything is kind of smooth. I'm doing my AFib ablations and I'm doing research at the same time.
I'd say that Dr. Valderrama was smarter than I was, because it took me a long time to figure out I couldn't be a physician and a basic scientist. I had to do one or the other. And I went the other way. I decided to go toward the basic science, but you can't do both well. When I was doing both, I always felt like I was doing it halfway, because you're competing against basic scientists who, this is their job. This is what they do day in and day out. They're working just as hard as you are, but they're doing it all the time.
Yeah.
So what you need, and what you found was a basic science partner that you could talk to, you could have coffee with, and you shared some vision for your research. And you guys have done a spectacular job. So thank you for leading the way for us. Any other comments on Dr. Valderrabano and Francisco Altamirano's? Let's turn to Carly Figueroa and Maham. Talking about a little bit about their collaboration, which has successfully gotten Costas funding, and tell us a little bit more about what you guys are up to.
We thought about what to share with the audience, and do we share with you what we do as a researcher, as a physician, or do we share with you how this combination and collaboration work? And we choose the latter. I put my few cents in, Carly, if you could finish that, if you would. So I think knowing yourself is the first step. Knowing what you want to be, who you are, and what can you contribute to the science. For me, when I came in, I was a vascular surgeon. I did PhD in biomedical engineering from 2004 to 2008. So I was away from biomedical engineering for years. But I came in as a surgeon, and I continue to be a surgeon and operate in the operating room. But I came to the same realization that I can't compete with the scientists. I cannot make the 24 hours 30 hours. So knowing yourself and knowing what you want to do is the first step. Second is knowing what the chair of the department wants you to do, knowing what the alignment of the institution is, and align it for yourself as what you want to do. So walk in a parallel lines and have their goals, your goals. And the third thing is massive collaboration. When me and Carly started talking about our interests, our frustration from different clinical problem, that's where the sparks came in, and that's where we found common ground. So the third thing is the massive collaboration. And the fourth thing is owning the problem. Whatever you're working with, from diagnosis, from treatment, from surveillance, and etc., owning that problem and understanding it very well, understanding who are the key people in the world that do that kind of research, and understanding their research. Those are the 4 points that I thought I'll share with the audience.
So I'm not a big coffee drinker, so that's not going to work for us. But what works for us is Dr. Rahimi he'll just text me when a case gets delayed or whatever. We have a Teams group set up between ourselves, and we both hop on Teams when we're both free, and we try to create agendas and goals for the next time we meet, which always keeps us on track. And I think it works really, really well. And we don't leave until we've decided when we're going to try to touch base again. So we always have the goal each time we meet to when are we going to talk again and what are we going to talk about next time, so that we stay on track. And also I have this mentality of the lab as a playground. I was very fortunate in having previous mentors that wanted me to feel free to try different things in the lab, take apart equipment, play with things, test ideas. And so I want to foster that type of environment. So whenever he has an idea, I say, come on by, let's try it. I'll get out the pig aorta, you do the dissection. We had pictures of us, him doing the dissection, me helping. And so we try to make it fun. And that's what really drives both of us, I think. We both have young children. It's hard. We respect each other's schedules. We respect each other's time. We make the most out of the time that we get together. And we try to do all sorts of things, from review papers to grant applications to internal funding calls, and mentoring. Both of us really, really want to help mentor the next generation and encourage that type of activity.
Carly and Maham, tell us about the device that you guys have developed or are developing. I know there's been a few, but tell us about one that you are most excited about.
Detail we can get, the patent is still in the process. But I don't know about the details. That
I can say that one thing that works for us is we don't judge each other's questions. We are very fostering, like, no question is stupid. So I'll say, hey, do you ever deploy a balloon and then move it to another spot and then deploy it again? Like, is that a stupid idea? And he'll look at me like, no, there are cases, there are scenarios where you might need to do that. And then he'll start to explain to me the types of scenarios when you might need to do something like that, or what size balloon you might need to get different parts of the leg towards the foot. And so he'll be very patient with me and teaching me these types of things. And then it will start triggering ideas in my head about, oh, okay, well, you know, if we need to have a smaller balloon, maybe we should think about, you know, other types of additives or polymers or things like that. And we just kind of throw ideas at each other and then.
Great. But to answer your question, looking at what as Dr. V said, what frustrates us in the clinic and bring that to basic scientists and trying to solve that. For instance, in the treatment of peripheral arterial disease, endovascular treatment has a limit. And understanding where that limit is and how can basic science solve it. For instance, she came in and said, hey, I attended a lecture and they were using this polymer for coating of different materials. And that caught my attention. And we learned about that polymer, and that's where the technology just developing. It's the egos are out when we have meetings, and I think that's very important.
Thank you, Mohammed. I just want to thank you while I'm up here for the collaboration that we've had together too. So, and it looks very exciting. Thank you for getting that tissue for us and working with us. Why don't we turn to our last couple? It's Khurram Nasser and Henry Pownall. Tell us a little bit about your collaboration. I think it resulted recently in a successful R1 application. Tell us about that.
Well, I want to thank, first of all, Dr. Lumsden for introducing me to Khurram about 4 or 5 years ago. That was the beginning of the whole thing. I thought it was incredibly exciting to have someone who, on a Venn diagram, we had some thoughts that intersected with each other. And so we started talking about this collaboration. It started as part several years ago where we found a bacterial protein that delivered with an adeno-associated virus lowered plasma cholesterol, but it lowered plasma HDL cholesterol. So there was a moment of sadness until we found out that all these drugs that raise HDL cholesterol failed. Some of them were really spectacular, but the endpoint was no decrease in mortality. So we were working on a mouse model of high HDL cholesterol, and this mouse model had HDL with 5 times more free cholesterol than wild-type HDL. And these mice developed atherosclerosis. And these mice, if you test their HDL, they put more free cholesterol into macrophages, the important cell type in atherosclerosis, by a factor of 4 than the wild type. So we thought, could this be true in humans? So we set up some meetings. We had a wonderful cardiologist who worked with Khurram, who went back to Spain, who helped develop it, a biostatistician. I did learn that it's different from bench research, and there's no instant gratification, right? You have to wait for years. So we got an NIH grant. We will enroll nearly 400 people with medium, high, and low HDL, and Dr. Nasser's group will provide the calcium scoring data that allow us to correlate HDL function with the occurrence or non-occurrence of coronary disease. And so, just as a sidebar, I'd like to add that one of the most important peoples in a research group are the ones that I call middle management. They're not the big cheeses. They're the people who actually do the work. And when somebody asks me, who do I hire when they come on board here? I say, hire somebody that wants to stay with you for 20 years because they will become your laboratory memory. And you can't do everything. Your postdocs, your fellows, they'll go in and out every 2 or 3 years. And so I have one person been with me 20 years, one 14, and the other one going on 12. And that was the first hire when I came here in Methodist. So that's our short story. But I want to thank Dr. Nasser again. Opportunity to do this is going to be terrific.
Khurram, tell us what you're excited about this collaboration and what is going to be the clinical ramifications.
So, my first introduction to high HDL was almost 10 years back working in Arthur Agatston Clinic, where introduced that actually high HDL may be associated with higher risk, especially seeing a lot of women with no risk factor. So we started having this interesting thought process and some of our prior work in high HDL and demonstrating for the first time that truly it is the atherosclerotic burden that most of you would know that my interest is around resilience, around people who should have disease and don't have, and where we clearly, and then again, this is kind of somebody that's not as a vascular biologist, see that as a simple phenomenon, HDL as a dump truck, picking up the junk and throwing it back, but is it really the functionality? And so that's where we started working on Horsecal. You need a biological surrogate. You can't really wait for heart outcomes for studies like this, and calcium testing really provided that for us. But more importantly, again, highlighting the value of the registry that we created, because for everyone out here, it is a great resource for providing pilot data. So we were able to really tap into this and thousands of calcium testing, and of course their HDL to really demonstrate that relation. But the key element was how do you find it reaching with the highest HDLs, which are rare to find with HDL 100, 125. In our registry, within our system, we have identified almost 600 individuals with those HDLs that you can actually tap into. And that was the one major plus that came back from the NIH, because we had an ability. So not only of interest, but we could find the pilot data, we could find the patients. And then this partnership, from my perspective, is leading to the next step, which I'm truly interested in, the genetic FH and elevated lipoproteinemia. And one of our beliefs is could there be a mechanism where this high functional HDL could explain why these increases are not developing atherosclerosis. So again, a wide spectrum of benefits that would be coming out from this amazing.
Wonderful. Great comments, Karam. And thank you to the panelists for their words of wisdom, and keep up those great collaborations.
Thank you, John. And it is time to hand over some prizes. Can I ask Dr. Cook and Lumsden to come with me here? So we're going to have two, first prize and second prize for basic sciences, first prize and second prize for cardiovascular surgery, and we'll have three prizes because we had more than 30 abstracts for cardiology, so we'll have first, second, and third prize.
All right. John?
Okay. Who is your second winner?
The envelope, please.
Drum roll.
I've got an email here somewhere.
Do you want to mix this?
Just from memory. First of all, thanks to Natu Lei, who did the judging for our group. I don't see Natu here right now, but thank you. Oh, there she is. Thank you, Natu. In second place, drum roll, for her work on telomerase and its effects to rejuvenate progeria cells and extend the lifespan of an animal model of progeria is Anahita Mojiri. If she's here to accept her award, Anahita.
Absolutely right.
And in first place, for their work with computational algorithms to link spatial transcriptomics and histology, is your postdoc, Guanyu Wang, and maybe you can introduce your postdoc, because I don't see them here. Congratulations.
Such a picture?
Yeah, a picture. I guess Dr. Zarfi wants pictures of the awardees. Where's Anahita?
She here. You're supposed to yeah. Oh, there you go. Yeah, there. You know, I haven't anything on the left side. Cut to it. Oh. I'll set kind of picture the number. There you go. Yep, let's point. Take that. One.
Great. Thank you.
Okay, so next up is the prizes in CV surgery. Another drum roll, a bigger drum roll.
Thanks.
Yeah. And second prize goes to Bright by Name, Bright by Nature. I think that may stick with you for some of the work that he's been doing with Dr. Peden and dialysis access. So come on forward, Bright. And first prize goes to Judith Soar from Dr. Roy's lab. So Judith and her work on MR imaging in the lower extremity. We're very proud of both of them.
Biden.